Hi guys, Assalamu alaikum. My name is Anis Fatma and I'm a final year medical student, and today we will be studying about abdominal and inguinal hernias. Note that these surgery lectures are compiled from the Irfan Masood and Brilliant Love, and we are on the lecture number 1. Now, as we are on the topic of hernias, what is hernia? Hernia is defined as a protrusion of a viscus or a part of viscus through an abnormal opening in the walls of its containing cavity. Viscus is any hollow organ of your body. Causes of the hernia could be the anatomical weakness like failed muscle development, smoking, structures which are passing through the wall already, like for example drains which are placed post-operatively, and high intra-abdominal pressure which could be due to obesity, malignancy, cuffing, and chronic straining, etc. As we already learned that hernia is anything like viscous or a part of viscous which is coming out of the walls of its containing cavity, so it must be in the form of a sac, right? The contents of the hernia would include the sac, its covering, and the contents which are inside. The sac could be the diverticulum of the peritoneum if we are studying about the abdominal hernias, and then the covering of it would be abdominal wall muscles, and the contents could be omentum, intestine, Meckel's diverticulum, or vermiform appendix, etc. Some special terms, or we can say some special types of hernias, could be the Richard's hernia, which is the portion of the circumference of the intestine which is trapped inside the hernia, or the Litter's hernia, in which a Meckel's diverticulum is trapped inside. The Amiens hernia, in which the content of the hernia would be the vermiform appendix, and the Meadle's hernia, in which the W-shaped loop of the small intestine is trapped inside. And yes, hernias can be classified into various different types, including the reducible hernia, the irreducible hernia, obstructed and incarcerated hernia, and strangulated hernia. So let's study these one by one. Reducible hernia. It refers to the hernia in which the contents can be returned to the abdomen. It has a positive cuff impulse. Now, most of the times, the hernial sac is not visible when we examine them when the patient is lying supine, but when we ask them to cuff, the hernial swelling or the sac would come out or would bulge out. This is the form of the reducible hernia, and the intestine would gurgle on reduction, and the first portion of the intestine would be more difficult to reduce than the last one. The omentum, which is the part of the reducible hernia, is doughy, and the last portion is very difficult to reduce. The second type of hernias are irreducible and incarcerated hernias. Irreducible hernia is the type of hernia in which the contents cannot be returned, but with no other complications. Like, for example, whether the person is coughing, whether the person is sitting, or whether the person is lying straight, the bulge or the swelling of the hernia would be visible straight out. The incarcerated hernia is when the contents of the hernial sac are fixed somewhere, like the fixation of the contents within the hernia sac as a result of the adhesions which are formed when there is a chronic inflammation, etc. Unlike the strangulated hernia, it is non-tender, like there is no pain and there is no systemic upset, like no gastrointestinal symptoms of vomiting, nausea, etc. Unlike the obstructed hernia, there is irreducibility without other symptoms, and it is almost always diagnostic of the omentocele. But yes, the irreducibility does predisposes this type of hernia to the strangulation, which could be included in the complications of the irreducible hernia. The third type of the hernia is obstructed hernia, and it is the type of hernia where the intestine is obstructed but it has a good blood supply, so there is no strangulation. It is associated with the gradual onset of the colicky abdominal pain and tenderness over the hernial site, which is less severe than the strangulated hernia. There would be pain, there would be tenderness, but there will be no overlying skin changes because there is no strangulation, and it can lead to strangulation, yes, in the near future. Strangulated hernia. It is the type of hernia in which the bowel's blood supply is obstructed. Now, when the bowel's blood supply gets obstructed, it could lead to the skin changes, it could lead to the necrosis of the contents of the hernia, and it is more common in the femoral hernia due to the narrowness of the neck and its rigid surroundings. It is associated with the sudden onset of the colicky abdominal pain and tenderness over the hernial site, along with systemic signs like nausea, vomiting, and it can lead to the gangrenous formation of its content. Gangrene could occur as early as 5 to 6 hours after the onset, and gangrene occurs at the areas of constriction and then at the anti-mesenteric border. इनिशियली सबसे पहले वहाँ पे वीनस ब्लॉकेज होता है बिकॉज वहाँ पे वीनस थेसिस हो जाती है, बट लेटर ऑन इट कुड ऑल्सो लीड टू द आर्टीरियल सप्लाई की ऑब्स्ट्रक्शन एज वेल. Now, how would you divide the inguinal hernias? Inguinal hernias are the hernias of the inguinal region. There are two different types which include direct inguinal hernia and indirect inguinal hernia. The direct inguinal hernia is when the hernia is within the Hasselbalch's triangle, while the indirect inguinal hernia is when it is lateral to the Hasselbalch's triangle. Now, it is very important to know what the Hasselbalch triangle is, so we are going to study about it. The important terms to understand the inguinal hernias are inguinal rings, and there are two types of inguinal rings, including the superficial inguinal ring and the deep inguinal ring. So the superficial inguinal ring, it is a triangular aperture in the aponeurosis of the external oblique muscle, and it lies 1.5 centimeter above the pubic tubercle. Now, there are several layers of the abdominal wall muscles, which include the external oblique muscle, the internal oblique muscle, and the transverse abdominal muscles. So, yes, the aponeurosis of the external oblique muscle, about 1.25 centimeter above the pubic tubercle, is basically the inguinal ring, which is superficial. Then there are deep inguinal rings, which are U-shaped condensation of the transversalis fascia, like the fascia of the transversalis muscle. It lies 1.25 centimeter above the inguinal ligament, which is midway between the symphysis pubis and the anterior superior iliac spine. Now, as we have already studied about the superficial and the deep inguinal ring, we will look at what the inguinal canal is. Inguinal canal is about 3.75 centimeter long, which is directed downwards and medially from the deep to the superficial inguinal ring. If you look at your inguinal region, there is a canal that goes from the lateral side to the medial side. Laterally, there is a deep inguinal ring. Medially, there is a superficial inguinal ring, and it always goes downwards and medially. It transmits two important structures, that could be the spermatic cord, which is in males, and the round ligament of uterus, which is in the females. And then there are inferior epigastric vessels, which lie posteriorly and medially to the deep inguinal ring. Remember, we know that deep inguinal ring is basically located laterally. So when we come towards its medial side and slightly posterior to it, there would be the inferior epigastric vessels. What are the boundaries of the inguinal canal? There are four different boundaries, which are posterior, anterior, superior, and inferior. When we look at the posterior boundary, it is formed by the fascia of the transversalis abdominis muscles and the conjoint tendon. When we look at the anterior boundary, it is formed by the external oblique aponeurosis plus conjoined muscles which are laterally. Acha, superiorly there would be the conjoined muscles, the same muscle that is going from anterior side towards the posterior side, and then there inferiorly there is inguinal ligament. As we studied that in males, the inguinal canal is transmitting the spermatic cord. What is inside the spermatic cord? It contains three vessels, three nerves, three structures, and three coverings. So, what are the three vessels? This is basically the testicular artery, the cremasteric artery, and the artery to the vas deferens. And all of these arteries are literally very important. Then we have three nerves, which are the genital branch of the genitofemoral nerve, ilioinguinal nerve, and autonomic supply to the testicles. Then the three structures would be vas deferens, pampiniform venous plexus, and the testicular lymphatics. And three coverings of this spermatic cord would be the external spermatic fascia, the cremasteric fascia, and the internal spermatic fascia. So, what were the three vessels? Testicular artery, cremasteric artery, and artery to the vas deferens. What were the three nerves? These were the genital branch of genitofemoral nerve, in ilioinguinal nerve, and the nerves to the testicles. Then there were three structures like the vas deferens, the pampiniform venous plexus, and the testicular lymphatics. Initially, we studied about the Hasselbalch triangle. So, Hasselbalch triangle is a triangle in the inguinal region with its lateral boundary formed by the inferior epigastric vessels. Where were the inferior epigastric vessels were located? They were located medial to the deep inguinal ring. So, medial to the inferior epigastric vessels lies the Hasselbalch's triangle. Then medial boundary of the Hasselbalch's triangle are formed by the lateral border of the rectus sheath. Where is the rectus sheath? Rectus sheath is in the middle. So it forms the medial boundary of the Hasselbalch's triangle. And then inferiorly there is inguinal ligament, which is also the inferior boundary of the inguinal canal. And that's it for today. We will see you in the next lecture very soon.